Adenylosuccinate LYASE deficiency. Adenylosuccinate LYASE deficiency is a rare autosomal recessive metabolic disorder characterized by the appearance of succinylaminoimidazolecarboxamide, riboside, SAICAR, riboside, and succinyladenosine residue in cerebrospinal fluid, urine. These two succinylpurines are the dephosphorylated derivatives of SAICA, ribotide, SAICAR, and adenylosuccinate SAMP, the two substrates of adenylosuccinate LYASE ADSL, which catalyzes an important reaction in the de novo pathway of purine biosynthesis. ADSL catalyzes two distinct reactions in the synthesis of purine nucleotides, both of which involve the beta-elimination of fumarate to produce aminoimidazole ribotide AICAR from SAICAR or adenosine monophosphate AMP from SAMP. Types. ASL is divided into three categories based on the severity of symptoms: the fatal neonatal form, type I, and type Roman II. However, as symptoms occur along a spectrum, there are no set criteria to determine which category a patient should be ascribed to. Fatal neonatal form. Patients with this form of ASL present with fatal neonatal encephalopathy, respiratory failure, a lack of spontaneous movement, and intractable seizures. Possible prenatal symptoms such as microcephaly, intrauterine growth restriction, loss of fetal heart rate variability, and hyperkinesia have been reported. Death occurs within the first few weeks of life. Type I. This is the most common form of ASL. Symptoms become apparent in the first months of life and include seizures, microcephaly, and severe psychomotor retardation or purely neurological. Some patients display axial hypotonia, peripheral hypertonia, and normal tendon reflexes. Autistic-like behavior, including pro-eye contact, stereotypies, agitation, tantrums, and self-injurious behavior may occur. Type Roman II. This is considered to be a mild to moderate form of ASL. They may demonstrate a milder degree of psychomotor retardation and transient visual and auditory contact disturbances. Seizures, if they occur, begin later than in type I, typically between 2 and 4 years old, but sometimes as late as 9 years old. Speech is impaired, with receptive language skills and nonverbal communication skills being better than expressive language skills. Ataxia may occur and cause increasingly severe gait disturbances. Signs and symptoms. Among the signs and symptoms of adenylosuccinate LYASE deficiency are the following: aggressive behavior, microcephaly, autism, brachycephaly, mild cerebellar hypoplasia, seizures. Pathophysiology. Adenylosuccinate LYASE deficiency is responsible for a range of symptoms that involve psychomotor retardation, often accompanied by epileptic seizures and autistic features. Two common theories were proposed to account for these effects. The first is that they result from decreased concentrations of purine nucleotides needed for purine biosynthesis. Decreased concentrations, however, could not be found in various tissues taken from ADSL deficient people, probably because purines are furnished via the purine salvage pathway. The second is the buildup of accumulating succinylpurines causes neurotoxic effects. In the severely affected individuals, the concentration levels of SAICAR, riboside, and residue are comparable, whereas in people with milder forms of the disease, the ratio of residue is more than double that of those more severely affected, while SAICAR riboside concentration levels remain comparable. Biochemical studies of the enzyme have focused on proteins of ADSL from non-human species. The ADSL structure from the crystallized protein of Thermatoga maritime has been used, along with DNA sequencing data, to construct homology models for a variety of other organisms, including human ADSL. A variety of studies have been done using the equivalent enzyme from Bacillus subtilis, which shares a significant percentage of identity along with about some percentage of similarity in amino acid sequence with a human enzyme. Homology models overlaid on each other show a high degree of overlap between the enzymes. The family of enzymes to which ADSL belongs and that catalyze beta-elimination, in which fumarate is one of the products, are homotramers with 4 active sites composed of amino acid residues from 3 distinct subunits. Much is known about the active site of human ADSL due to studies of the active site in the B subtilase ADSL through affinity labeling and site-directed mutagenesis. While there is some variability among species in the sequencing of ADSL, the active site of the enzyme contains many residues that are conserved across species and have been shown to be critical to the enzyme's function. His centers seem to serve as the general acid and base catalysts and are critical to the catalyzing reaction of the substrate. His seems to enhance the binding of the substrate's phosphoryl group and orient adenylosuccinate for catalysis. All 3 histidines are conserved throughout the 28 species for which the structure of ADSL is known. Cl2 and LYASE2 have also been shown to contribute to the active site, indicating there are 4 active sites, each of which is formed from regions of 3 subunits. ADSL deficiency in different people is often caused by different mutations to the enzyme. More than 50 different mutations in the ADSL gene have been discovered. Diagnosis. In terms of the diagnosis of adenylosuccinate LYASE deficiency, one should look for exam/method MRI demonstration of succinylpurines in extracellular fluids like plasma, cerebrospinal fluid, and / or urine using high-pressure liquid chromatography with or without mass spectroscopy, genetic testing, genomic cDNA sequencing of the ADSL gene, and characterization of mutant proteins. Treatment. Treatment of adenylosuccinate LYASE deficiency can be done via epilepsy management with anticonvulsive drugs. Additionally, the following options include D-ribosine administration, ketogenic diet, adenylyl L-methionine. Prognosis. The prognosis of this condition in childhood usually has a stable outcome, whereas in neonatal is almost always fatal, according to Chirkert et al.